Welcome. I'm Paul Rubery. I'm the chairman of the Department of Orthopedics, and it's really my great pleasure and privilege to introduce the 2017 Distinguished Alumnus Award winner, Dr. Randy Rosier. So Dr. Rosier was born in York, Pennsylvania, and attended Dickinson College, where his focus was actually on physics and mathematics. And those of you who attended the Whipple dinner last evening heard Randy relate the influence one of his Dickinson professors had on Randy's decision to come to Rochester to study biophysics, an influence which ultimately helped to permanently alter the direction of orthopedic research at Rochester. Dr. Rosier entered the MD PhD program in the Department of Biophysics and received his MD in 1978 and his PhD in 1979. His dissertation was entitled Calcium Transport in Vesicles Energized by Cytochrome Oxidase. At the time, this would have seemed the furthest one could move intellectually from the vision of an orthopedic surgeon. Undeterred, Dr. Rosier moved to the University of Iowa, then and now one of the foremost places for training in orthopedic surgery. He finished his residency in 1984, complete with an embedded research fellowship wherein he investigated the role of mitochondria in endochondral ossification. Mac Everts recruited Randy to the Rochester faculty in 1984, whereupon Randy and his long-term collaborator and friend, Ed Puzis, set about creating a new focus and research specialty that I like to call molecular orthopedics. They, with the help of numerous colleagues, students, and residents, established Rochester as the undisputed center of basic research in all matters musculoskeletal, a position that we continue to enjoy today. Randy and his team had the foresight and the skill to realize that understanding basic scientific mechanisms was the key to improving clinical care. Today, work Randy began with others 25 years ago has resulted in a clinical trial assessing the ability of teriparatide, a fragment of parathyroid hormone, to influence the natural history of osteoarthritis. I submit a very long way from the metal bending and bone crunching research prevalent in orthopedics in the 1970s. Clearly, the recruitment of Randy was the creation of our Center for Musculoskeletal Research, which this year has just under $30 million of extramural research funding and is the acknowledged worldwide center of excellence. Randy is a master clinician. He's an academic surgeon who is a tremendously talented technical surgeon. His ability and willingness to perform all manner of complex surgeries, particularly for patients with musculoskeletal cancer, is legendary in our department. His bedside manner and his patient-reassuring style have been models for a generation of residents. Randy has served the university in many ways, including as director of the Center for Musculoskeletal Research, as Dean's Professor of Orthopedics, as interim Senior Associate Dean for Clinical Research, and as Whaley Professor and Chair of Orthopedics. As chairman of our department, he oversaw tremendous growth and is responsible for the recruitment and mentoring of many of the cities and many of the university's leading young orthopedic surgeons. If there's an award in our field, it's likely that Randy has won it. He was an American-British Commonwealth Traveling Fellow. He won the Kappa Delta Award given annually for the most outstanding orthopedic research, and he's a Shands Award winner from the Orthopedic Research Society. He served on the American Board of Orthopedic Surgery and has had leadership roles in several societies. He's published over 140 papers and 30 chapters. Randy is a polymath. In addition to his tremendous accomplishments in our field, he has amazing knowledge about travel, food and wine, astronomy, and all sorts of mad scientist projects. Last night he told me how he designed and built his own geothermal system to heat an indoor pool at his home in Rochester 20 years ago. I think that concept is still ahead of its time. Through it all, Randy has remained one of the most humble, giving, and generous people that I've known. Many of us owe large parts of our success to his help and suggestions. During his time at Rochester, he was tireless and truly selfless in his devotion to others. Somehow, Randy was always the smartest person in the room, and yet he always had time to entertain our ideas and suggestions. This is undoubtedly a rare skill. It's an honor and an immense pleasure to present to you the 2017 Distinguished Alumnus Award winner, Dr. Randy Rosier.
Thank you. Well, thank you, Paul, for your very kind remarks. I'm certainly humbled and honored to be here and to give this talk today. I feel like the best thing that I could do after that is shut up and leave. It can only go downhill. But anyway, it is a pleasure to be able to talk to you. I feel a little bit like I'm carrying coals to Newcastle. You probably wonder, why would I talk about such an uninteresting or a topic like this at an institution that has really become a leader nationally and internationally in integrating clinical care and research. And but it's something that drove my enthusiasm and passion in orthopedics and in research, and so you'll have to indulge me. This is a little bit of my background that Paul has really already reviewed, but it was being in the MD PhD program here at Rochester that it just gave me the passion for pursuing research, trying to be able to see the connections between research and clinical care, and trying to be able to make new discoveries that would be relevant to taking care of patients. I did my orthopedic training, as Paul has mentioned, at University of Iowa. I had great mentors there who helped me along the way with research and teaching me clinical skills. And then one of my early career mentors, Dr. Everts, recruited me to come back to Rochester, where I set about trying to develop an orthopedic oncology service and a metabolic bone disease service, as well as spending time doing cartilage research, which I had become very interested in. In 2000, when I became chair, succeeding Dr. Richard Burton, who was also one of my career mentors, I helped establish the Center for Musculoskeletal Research at a time when the leadership of the medical center had recognized the need and value of multidisciplinary research operations and created the center's programs. And so that is how I got interested in this interface between clinical care and research. The one thing I learned real quick trying to do this, as I was trying to become a clinician scientist, is that you need two ingredients mainly. You need time to do these things. You need time for your patient care, but you also need protected time for your research. And also you cannot go it alone. You need a team, both in a clinical sense and also in a research sense. And so I always say the time and the team are the way for clinician scientists to become successful. Now, there are many forms of being able to integrate research and clinical care. And I don't mean to suggest that becoming a clinician scientist, it's one pathway. But also I learned here in Rochester that collaborations between clinicians and scientists are every bit as effective and important and easier to forge because of these time and time commitment issues. There are barriers, many barriers, to becoming yourself someone who works in both spheres. Increasing technical complexity and even divergence of our languages between clinicians and people doing basic or clinical research creates barriers in understanding each other or appreciating the importance of certain aspects of what we do in these two spheres. The length of time of clinical and research training is a barrier. It takes a long time to get clinical research, clinical training as well as then research training, and you could be stale at either one by the time you get done with the other. So it's a challenge. There are financial issues and disparities in what one can earn. At the end of the day, whether you're doing clinical care or doing research, and those vary in different places and different models, and they vary with the vagaries of funding, which creates some level of insecurity for many scientists. Then there's the time demands of juggling research and clinical career components, and just the busyness of our professions, let alone trying to maintain two professions. Well, when I was fortunate enough, in fact, astonished to be accepted into the MD PhD program here upon advice of a physics professor advisor I had as an undergraduate, I didn't even know such programs existed, and I was really interested in biology and medicine, but also in very basic research, as Paul pointed out. I drifted from that a little bit over the years, but this program, this medical scientist training program, when you think about, well, what are the things that can be done or have been done to try to get over some of those barriers? Well, one of them is, I think, the medical scientist training program, which remains in place now 53 years since its inception. There are currently 47 of these, and they inject about 1,000 people who have been trained in medicine and research every year into the care provision and research communities. And there have been 10,000 people since 1964 who have done this. It creates a steady infusion of individuals with research interests and with training in various fields of medicine. And I think that helps to bridge the dialogue between clinical science and care provision and also basic research. Career paths vary. Not everyone that completes these programs becomes a scientist. A few don't become a clinician. But it really promotes interaction and dialogue. So I feel it's still a very valuable program. And it's the thing that gave me the passion for what I did for almost 30 years here at the University of Rochester after Dr. Everett recruited me to come back here. Student and resident research. Many institutions, and certainly this institution has been a leader in this, has fostered programs for medical students to take a year out or have some type of research exposure for shorter periods of time. This has been really notable at this institution. Many residencies here promote, including orthopedics, promote resident research projects or year-out training, research training for residents. And again, it fosters the dialogue and the interaction and allows a contagion of excitement about a clinical problem by a scientist and vice versa. Another thing that's really helped knock down some of these barriers to doing this is the amazing change in information access and communication. The ability to share data so easily, electronically now, facilitation and notification of meetings, and even carrying out Skype-style conferences where people are at remote sites doing clinical work or research or at other institutions which are collaborating. It's really been a boon to this interaction among clinicians and scientists. And electronic medical record access and clinical data storage. Here at the U of R, a major program has evolved, and I'm happy to point out that orthopedics has had a leading role in this with Dr. Judy Baumauer and Dr. David Mitten in data acquisition for outcomes of treatments and accessing that for clinical research. And this is the wave of the future, and they have really built the infrastructure here that this is going to truly take off. Collaborative manuscript and grant preparation. Really, this is not something new to Rochester. This has always been a collaborative place, but it's one of those ingredients that breaks down these barriers and I think allows a lot of progress in medical research and applied medical research or translational research, as you might say. The team approach, I mentioned that the team business is really important, and it's important both in having clinical teams. And Dr. Everts founded the department with a philosophy that we needed to have subspecialties in orthopedics back in 1974. And Dr. Burton, who succeeded him as chair in orthopedics, had the notion that we needed to have depth, not just breadth among specialties. And this allowed the evolution of clinical teams where people could cross-cover for each other and help with emergency problems and so on. And that really was a key ingredient in enabling some of the clinicians in our department to pursue scientific pursuits in a serious manner. Job sharing arrangements. Dr. Burton was very supportive of the notion that I had of recruiting another clinician scientist, Dr. Regis O'Keefe, who had trained at this institution and then did his fellowship training at Harvard, to come back here. And we had a job sharing arrangement where we had one very busy clinical oncology practice, but we shared it on 4-month rotations. And on the alternate 4 months, one of us pursued research, wrote grants, and helped the other partners research along. We did this for like 15 years. And it was extremely successful in both of us being able to have continuous NIH funding for decades, and really helped us. But it's not a model that has caught on in surgical specialties, really. It's kind of hard to engineer that. And but certainly in other fields of medicine, it's not uncommon to have these type of job sharing arrangements. It is a way to protect time. Critical ingredient is this culture of collaboration. And that's something that was here when I got here. And it is something there where the University of Rochester really shines. And when I was just knocking about as an assistant professor, trying to figure out how to do research and what I wanted to do, people would just lend a helping hand, much more senior people than myself in research areas, in the cancer center and other departments, taught me all sorts of things and spent a lot of time doing it to help my research so that I could be productive and serious about this pursuit. I think there's a real importance of clinical observations in guiding research, so-called translational research, or medical research that's applied to clinical care. It's always been talked about as bench to bedside. You discover some drug at the lab bench or something like that, and you eventually test it in perhaps some animal model and then in a human clinical trial, and that's how research ends up modifying clinical care. But actually, in my experience, it's been as much the other way, where an observation of someone taking care of patients has led to collaborations with other scientists to say, now, wait a minute, what is this? And led to entire research programs. So I think this works both ways. And I think the exciting aspect of having a clinical perspective or clinical contact with patients in the context of being involved with researchers or involved with research yourself is that a single clinical observation can lead to entire new research programs and ultimately to new ways of treating or at least understanding a patient's disorder. And I'm going to give you a couple of examples of this, and because it influenced the way we built programs that eventually became the Center for Musculoskeletal Research. And those of you who are here from the center or from orthopedics, you have to beg your indulgence and suppress your groans, because these are slides you've seen time and again in the past, but I'm trying to make a point here. So anyway, the first one is our tremendous colleague and collaborator, David Hicks, in pathology department here, came to me one day and showed me this slide. And he said, I just don't get it. This is a lymph node from someone with prostatic cancer where they're doing lymph node dissections to determine whether there's metastasis. And he says, on the one side, all of the lymph nodes have this dirt on them. And, we've rechecked the microtome and rechecked the solution. There's no dirt in it. And the lymph node architecture was inflammatory. It was deranged. And eventually it turned out, again, having a scientific colleague and some curiosity, it turned out that all of the patients that had this dirt in the lymph nodes turned out to have total joint replacements in that side below this lymph node dissection. And we realized this was wear debris. Well, that's common knowledge now, but 25 years ago, nobody knew that. And so that was about the time that our current director of the Center for Musculoskeletal Research, Eddie Schwartz, joined us. And he was an immunologist and took an interest in this. And this was pursued. And this is a famous slide that's been shown many, many times that I got from Eddie years ago, showing this loosening of total joints that has been such a problem. And you can see on the panel here where the arrows are pointing to these large areas of bone reabsorption around this prosthesis. And eventually, through the research of Eddie Schwartz and Ed Pouzis and others in our research program, this led to the discovery that bone resorption stimulated by cytokines from the inflammation caused from this wear debris in these materials is what caused it to come loose. And this led to even clinical trials of methods of trying to prevent this pharmacologically, and also has led to quite a revolution in biomaterials to try to prevent having such inflammatory particles. And so it's really led to many programs here and elsewhere in the country. I mean, we weren't the only ones to do work on this. The next example I have is, I was taking care of bone tumors, and Regis O'Keefe, my partner, we were taking care of bone tumors, and, always vexed by pathologic fractures where the tumor would destroy bone. And it was always, I was taught when I was a resident, well, the tumor cells eat the bone. They eat the bone away, and that's what happens. And that's what we thought. Well, one day, in looking at a slide with our pathology colleagues who really helped us so much with the center, David Hicks and Brendan Boyce, we looked at this slide, and this is adenocarcinoma in bone marrow in a bone tumor that we had done some surgery on. And we noted all of these bone-resorbing cells, these large cells called osteoclasts. And we said, wow, that's a lot of, that's not normal. You see all this bone resorption, and yet we didn't see tumor cells resorbing the bone. And so that led to looking a lot deeper into this. And again, Eddie Schwartz, our former Senior Associate Dean for Basic Research, Ed Pouzis, a member of our research group, began to look at this seriously and realized before other people knew this, and again, this was a while back, that it was caused by the release of bone-resorptive cytokines from the tumor cells that kind of harnessed the bone, the host cells in the bone, and got them to chew away the bone to make room for the tumor to grow. We also looked at some cases of tumors that start in bone that seem to present often with a large soft tissue mass, like a lymphoma shown here. And we realized that there were little channels in the bone, even when the bone wasn't destroyed, that the tumor was getting out of the bone. And it was the same story. The tumor secreted cytokines that stimulated the bone destruction and made little channels so it could get out of there and grow. And, after this, and again, many other groups started to work on this, and eventually ways of preventing bone resorption is now a standard component of the treatment of all patients with metastatic bone disease. It is absolutely standard, and it's increased longevity, decreased fracture rates, decreased morbidity. And we don't take credit for all that, but we knew that this was what was going on really before it was common knowledge. And it led to a very active program. So these two observations, looking at a slide and having some curiosity about it, led to major programs in implant loosening and bone tumor growth and metastasis. And since then, Dr. Schwartz has gone on to study these mysteries of bone destruction and how it promotes and helps to maintain bone infections, and is working on really groundbreaking work with a recently large programmatic grant to try to find a cure for staph infections and osteomyelitis. So clinical observations lead to a lot of bench work. Come back to the clinic. The next example of this, of course, when I came here, I was interested in cartilage research. And for many years, we studied the cartilage through models of the growth plate, which is cartilage at the end of all the long bones that kids grow from. It is a complex and very ordered structure, as you can see in this picture. I'm not going into a lot of detail, but the cells proliferate and enlarge and they make bone, and that's how your bones get longer. And this is orchestrated and carefully controlled by autocrine and paracrine cytokines and growth factors. Factors that are secreted by the cells at certain stages, control how fast they grow, control whether or not they progress to form a scaffolding for bone. And we studied this, Regis O'Keefe and I, for a number of years. And we're very interested in it. And one of the important factors that is secreted by cartilage cells in a certain part of that growth plate causes them to grow but keeps them from prematurely forming bone is called parathyroid hormone-related protein. And it's what we call an autocrine regulator of cartilage. It stimulates proteoglycan production, the matrix of the cartilage, and causes the cells to proliferate. It prevents hypertrophy and maturation prematurely. And it shares the receptor with regular old parathyroid hormone, hormone that regulates calcium in the body. Well, one day, our pathologist friends, again, in one of our PATH conferences, were reviewing slides of, we used to look at all the slides with Dr. Hicks and Dr. Boyce that we were from specimens from surgery. And one of them was a hip replacement or knee replacement, I can't remember which, that one of us did, and was actually inadvertently stained for this PTHRP. During osteoarthritis, when the cartilage degenerates, there's an attempt at repair. The chondrocytes, the cells kind of proliferate, and these little clones or clusters that you can see here. And because we knew that this molecule drove this proliferation, we thought, well, maybe they produce this, and that's what makes an attempt at repair. Unfortunately, the attempt's rarely enough to prevent the deterioration of the cartilage. And again, we're looking at a bunch of research slides and then a few slides from a patient, and they did immunohistochemistry on him for all of these slides with it. This wasn't meant to be done, but we said, wow, that must be key in causing this. And does that mean that the receptor is there also? And in fact it was. And that what we realized is that maybe we could use parathyroid hormone to stimulate that kind of proliferation at an appropriate stage in deteriorating cartilage to create more cartilage. And Dr. Michael Zusick in the Center for Musculoskeletal Research elegantly carried out these experiments, which were published in a very high-profile journal a number of years ago, showing that parathyroid hormone can, in fact, in a very good animal model of osteoarthritis, prevent cartilage loss and can also actually regenerate cartilage. Well, he's now involved in this has progressed to a funded human clinical trial that will give us a definitive answer. Does this improve function? Does it improve pain or symptoms from osteoarthritis? Does it retard the course of it? Does it really regenerate any cartilage in humans? It's not going to make a normal joint, but it may be a new thing in our armamentarium, and I think the trial is set up. They'll be definitively able to answer this. Does this work or not? So again, this came from, an observation, taking care of patients, looking at their pathology, and having some curiosity about it, and some bright scientists around me to help pursue this. And I would point out that that's really pretty critical. Anything I may have accomplished over my almost 30 years on the faculty at Rochester was because of all the brilliant and talented people with a collaborative willingness that worked around me. And you can't put a price on that willingness to work together and be a team. I'll suffer you through one last clinical anecdote. Because I was taking care of metabolic bone disease, as was my colleague who's here, the vice chair of UCLA Orthopedics, Susan Bucata, who had been here with us and has developed a similar program at UCLA. We have to show them how it's done somewhere, don't we? She helped us with the osteoporosis efforts here and really expanded it. But I saw a patient in clinic that had a fragility fracture of her pelvis, those are very painful fractures. And this person was in a wheelchair and could not walk. And we were treating her osteoporosis carefully with maybe not very effective drugs because of the concern that we might interfere with the fracture healing. Well, the fracture didn't heal. And we followed this lady, and she was in miserable pain for months. And so one day, about 9 months later, I said, well, we need to at least be more aggressive about treating your osteoporosis. We've been holding off. This fracture's not going to heal. And we had pelvic fracture. It's kind of hard to quantify sometimes. So we had some serial CAT scans to document that it wasn't healing. There was no fracture callus. And so I said, we're going to put you on a new agent for osteoporosis. We're going to put you on this teriparatide, which we hadn't tried before. And, it's not for your fracture. It's to try to keep you from getting more of these. And so we did that. 6 weeks later, I was so struck when the patient who I'd been seeing every month in a wheelchair came walking in the door. And lo and behold, her fracture had healed. And Eddie Schwartz and Susan developed sophisticated techniques with our radiology colleagues here. And again, note the collaboration. And we're able to quantify this and prove that this fracture only healed once we started this therapy. It was quite an observation. But again, it's a single, somebody walks in the office and you notice something. And we know that PTH stimulates bone and cartilage cells, and these tissues are involved in fracture healing, and this had been used as a treatment for osteoporosis. So the long and short of it was we eventually found that this could enhance fracture healing, in particular in situations where the fracture wouldn't heal on its own. And this has been published. Some of this work has been published by my colleagues in the Musculoskeletal Research Center, and it's something that is used fairly commonly. So I really do believe that clinical perspective enhances this. It can add dimensions to basic research, and it may lead to new treatments even, and advances in care of patients. So it's a two-way street, this bench to bedside thing. And this is what fell out of these 4 observations, is all these programs, which were all funded programs with multiple NIH grants. And this is what we started with as the base for our building the Center for Musculoskeletal Research. So I think this integration of care and research, it's a really good thing. We started the center with the concept that it would be multidisciplinary, which was the philosophy here in the medical center at the time for centers. These are the many departments that were involved from the get-go in this, and there are more since. And we had the advantage of contiguous office and lab space for the scientists and the postdocs and students, and shared cores, and it created this tremendous interaction among faculty, medical students, residents, and the residents would talk to the attendings, and they would get interested in research projects, and the residents knew who to go and talk to get something done. So that really was central to trying to get this off the ground. We went through a couple of strategic plans. When I first became involved in strategic planning prior to doing it ourselves, I was here at the medical center, and I was involved in several of these for the Cancer Center and other entities here when I was a faculty. And I started out as a skeptic. I thought, you go and get everybody's opinion on this. What you're going to get is white noise with a couple of spikes that are the people that are the loudest voice. Is that really going to help? But I was educated about that process through my faculty mentors and people I worked with here and the administration at the medical center to realize, no, really things fall out of this that are like really, really important. And so I really came to believe in it. So we did have involved that from the get-go in the center and in the department. We had the notion, and Regis was really very strong in pushing this concept, that we needed to have internal multidisciplinary peer review of grants and also major publications or national presentations. So we had weekly meetings, and sometimes more than weekly. And that's been an ongoing thing now for 17 years, for the last 17 years. And it has, in many ways, been a contributory secret to our success. And, and speaking of the success of this center, we were doing pretty well when I was here. But not only the center has just risen to new heights under Regis's and then now Eddie Schwartz's leadership, but the entire medical center has. And it makes me think that the best thing I can take credit for is leaving. Look how much better things got. Maybe I caused it all. I don't know. But being disruptive, I don't know. But anyway, we also had centralized assistance with mechanics of grant preparation. And that was really helpful to getting clinicians to try to submit grants. Because you just don't have the time for the little details that are very kind of bureaucratic. And I'll talk a little bit more about pilot funding, but it's something I believe deeply in because I've seen it help so many people and get an idea off the ground and enough data so that it's mature enough it can compete for funding at a foundation or national level. I mentioned strategic planning, and part of our strategic plan for the center, our first strategic plan, was that we needed to achieve programmatic funding, we needed a training grant, we needed a core center grant. We would do this internal grant peer review process, which might, and it did, help to greatly accelerate all this. And we would recruit in focused areas for expertise, such as Professor Hani Awad, who has been our bioengineering star since his recruitment to BME and orthopedics. And we needed, for clinical research, which was our second strategic plan, really highlighted everyone wanted clinical research. We needed support staff for that. We wanted to promote that. And as I said, the current faculty have taken that to a whole new level by medical center-wide acquisition of outcomes data and access to it. And we have yet to see how amazing that's going to be in producing results in terms of understanding and efficiency of care delivery, value of care delivery in this medical center. And it's once again where this place is going to lead the country. I also felt that it was important that we have accessible infrastructure. Every place has infrastructure. You got infrastructure all over the place. But, if you're the little guy in the trenches, try to access it. The much more senior people have much more priority for good reasons. But you need to develop some point of service, some degree of point of service accessible infrastructure. So things like IACUC protocols, budgeting, accounting, parts of that can really be helpful to faculty to have personnel to do this. And we did, that was part of our strategic plan. And again, I think something that really helped. Now, the U of R, when I first came here, it had a number of aspects of the culture of people here that I think have really contributed to the entire multiple missions, tremendous success in this place over the last 30 years. First of all, clinical curiosity, which led us to pursue some of these observations, and many other people in the medical center have done this. Being curious about the etiology of things, efficacy of treatments, having some innovation and coming up with new treatments, making observations, but especially, in particular with the collaborative interactions, being able to connect the dots. That is really valuable. We had some modest resources to pursue questions, such as pilot funding and departmental resources, and programs for medical students, residents, trainees to get involved and get excited about it. And a key thing here has been accessibility of expertise. Go and ask one of the senior faculty a question, and they'll sit down with you and discuss it and be willing to convey that wisdom. There's a culture of collaboration. I've already said that. It's not new here. It has been here. It was here when I got here. When I was trying to start a research operation, senior people in the cancer center and biochemistry, biophysics spent a lot of time helping me, showing me how to do things. And I've already mentioned that, but I can't emphasize it enough how helpful it is to young faculty and trainees as well. I've already mentioned the most multidisciplinary research centers, and there's also been a long-standing community research history here in a collaboration with the private sector. And that really is not something that's common across the United States and has been tremendously productive with the advent of the Clinical Translational Sciences Institute. And I was really happy to be able to be a part of this program when we applied for this and eventually led to a successful Clinical and Translational Sciences Institute at Rochester here. We were one of the first round. And I think that has really helped provide resources and also just provide this interaction between the clinical sphere and the research sphere. I think this place also has a culture of mentorship, and I've mentioned some of that today. Leading by example role models, lending a helping hand, reaching down to help people, and multiple levels of interaction and advising occur here. And that's been the norm here. I was very lucky with mentorship. My mentor, Howard Long, the chairman of physics department at Dickinson College, was the one that said, you got to go to the University of Rochester. You need to pursue an MD, PhD. Well, those were some of the best advice I ever had. And when I came here, the dean of the graduate school, J. Newell Stannard, was my advisor. And he met with me every week for years in a tutorial session every week. Took time out of his valuable schedule to teach me about biophysics and biophysical techniques and so on. Frank Young, who started the medical science training program here, was the initial head of that. Later became the dean, and in collaboration with Dr. Everts, convinced me to come back here, which wasn't a hard convince. And Thomas Gunter was my PhD advisor, who taught me the beginnings of trying to be a credible scientist. And then when I went to Iowa, I had great advisors there as well in the research and clinical area, and lifelong friends really. And then when I came here, Dr. Everts and John Brand, who I'd known from graduate school, and Dick Burton, they mentored me along the way. So I had a remarkable series of astute advisors. Not everybody has that, but I think it's easier to have that here than most places because people are open and accessible to it. This shows some of my mentors, Dr. Everts and Dr. Burton, and Dr. O'Keefe, who was my partner in all this. He mentored probably more graduate students than any orthopedic surgeon in history through their PhDs and master's degrees and many, many medical students. And he was really a very effective, outstanding, and productive mentor. I'm not sure I was as good a mentor as I had. In fact, I'm sure I wasn't. And a cautionary note is just the professional busyness of trying to do all this stuff and trying to always remind yourself to make time for people that want to get your expertise, people, junior faculty, trainees, whoever. It's something you need to take a breath and take a pause and say, no, this can wait, I need to do that. And I'm not sure I did that as often as I should have. I'm sure I didn't. It requires, mentoring requires different individuals at different career points. There's not one person that's going to take you through your whole career, I think, and not in these kind of complicated fields. Advisory teams are a good example, such as PhD committees. Academic committees and departments have been very effective in many departments at mentoring folks. And I think we created that function by our interactive, multidisciplinary meetings in the Center for Musculoskeletal Research, where you got mentoring input from a group of people who were very expert in very many fields. So you had different perspectives. And of course, medical student and resident research, as I mentioned, abound here. I want to just say another word about pilot funding. I was privileged to become, along with Dick Moxley, my colleague who was in the Department of Neurology, to run the pilot funding program for the CTSI for a number of years. And, we had the notions of modest resources, rigorous review and input like we have in the CMSR. The goal of picking out catalytic things, or things that we thought would be catalytic, fostering the interdisciplinary, departmental, institutional, community, interinstitutional. And it was just amazingly successful for modest investments. The way this helped young folks with great ideas to get that data they need to go to the next level. And it remains a very successful program now under Eddie Schwartz's leadership. So orthopedics has remained having a role in that part of the CTSI, which I think is really critical. This is just an example from one of our rounds a few years back of the number of departments and collaborating centers, and 10 departments from the River campus, 10 collaborating institutions. It's an amazing diversity of groups coming together and producing great things. So I think the University of Rochester has these elements that I've said: a culture of inquiry, collegiality, collaboration, mentorship, and what it's led to at a time when that's what it took to be successful is team science, team clinical care, and multidisciplinary research centers, interdepartmental and interinstitutional collaborations, which is now really important for multidisciplinary and multi-institutional clinical trials. So the strengths here I've already talked about. There's just a couple others I want to mention quickly, and that is the geographical integration of this place. Granted, the electronic communication has ameliorated somewhat the need for person-to-person contact for everything. However, the fact that we are geographically pretty tightly located, easy access kind of place, easy for faculty, easy for patients, I think that's really a strength. And some places are so spread out, so large, so diverse, they don't get it with this collaboration and collegiality thing. And I think that's a really powerful ingredient. We have a diverse resource base. I've mentioned some of these, the departments, the administration. Mark Taubman talked earlier, a very exciting talk about the developments and the contribution and commitment of the administration to these academic programs. There are many shared resources throughout the institution, and again, emphasize the strong community research base in history and epidemiological and clinical trial strength that I think is about to take off to an entirely new level. And I think with some contribution from orthopedics, proud to say. Politics is always an issue. It can affect academic health centers at so many levels. It introduces uncertainty and unpredictable. I mean, there's a struggle every year about the NIH budget, and you don't know the mores of what is going to be in for clinical or basic research, and what may be not as hot in a given period of time. And so it introduces some unpredictability, which is always a challenge for academic health centers and the researchers in them, and these vagaries of funding and emphasis. Successful institutions, though, are nimble navigators. And the U of R has vision, and it also has nimbleness. And we've been able to really capitalize on things that fell into our sphere and adopt it and adapt to it, such as multidisciplinary research centers, clinical and translational research, et cetera, et cetera. And one point I just want to make, I think an area we may have fallen down on the job overall is in scientific advocacy. I'm horrified that there's such a thing even as anti-science thinking anywhere. I would never have dreamed of such a thing as a young person. But there's a perception of scientific shortcomings, and there admittedly are some. There is a downside to social media, that there can be information that may not be correct. We need to promote this. I think some enthusiasm for what science is going to do in the next 30 years for humanity in medicine, in biomedical research, in our interactions with patients. We need to have community outreach, involvement with community programs. And this is another place where the U of R just shines, really is an example to many other places. The mini medical school that they have here where lay people come and learn about the research in terms that are understandable. It has been very successful, both in raising funding, but I think more importantly in raising awareness among people who are going to be patients, who are going to interact with other people in the community and other patients. I think programs like this really need to go national. Once again, this place is exemplary. So having said all this, I think the University of Rochester, a place where you have a sense of academic community, the recent amazing success of the capital campaign for this institution demonstrates the loyalty and support of alumni. And your presence all here today is a testament to that. And I think our message to students, trainees, and junior faculty in this institution is that you have landed in a really amazing place. All you need to do is take advantage of these cultural attributes that this place has, and you will be successful, and the people here will help you to be successful. So, and that's how we've become ever better. I'd be happy to answer any questions. Yeah, Ron.
Andy, did anybody ever look at subcapital epiphysis and parathyroid?
We have not here. We did not do that. There have been some research on that at a histologic and immunohistochemical level by the group at Iowa, actually. But that was not one of the things that fell into our sphere of study here. But it's a good question. Yeah, Sue.
So, just to let you know, you have been a great mentor to many people, both within the university here as well as in the broader orthopedic community. But one comment many people would say, you always look like you are having fun.
Well, there were a couple days there where it got kind of iffy.
What do you think made it so that you really just could get such joy out of life?
You know, it's working with people you like, and that people that can also get excited about discovery and asking questions and trying to find ways to solve them. And I don't know that there's a simple answer to that, but I think that I would credit a lot of it to my colleagues, you know, the people I worked with. I worked with such amazing people, and amazing surgeons, amazing clinicians, amazing scientists, and it rubs off on you, you know. So anyway, yes.
In the medical institution that I worked at, there's been a pall cast over the academic nature of it because of the need to make the operation in the lab. And that has been a lot of pressure put on clinicians in the academic center to produce. And that's been a negative influence. I congratulate you for your enthusiasm and for what you say. I hope you can write this up.
Thank you. Well,
Write and give me a copy.
you know, it's the, you know, it certainly is been the same situation here. The pressure to produce financially, to be financially successful. And I mean, even when I was chair, I used to say, no margin, no mission. You know, if you're not making ends meet, you're not going to be able to accomplish any of these academic goals. And I think you heard a little bit from Dr. Taubman earlier today about the many things the institution has done to try to be financially successful and to be ahead of the curve. I tell you one thing, an example that I would credit to Dr. Burton, who laid the groundwork for an off-site multidisciplinary clinic in orthopedics shortly before I became chair of orthopedics. And that was phenomenally successful. It was unbelievably successful financially. And that enabled us to use the resources we had in endowment resources and other resources. And there were some pretty lean times on the research side. But it enabled us to not have to put a large burden onto the clinical department. It was successful. It generated enough revenue from the really very rapidly increasing business. And you know, under Dr. Ruber's leadership, we haven't seen anything yet. This is it's just going to go through the roof. Literally, they're going to have to build a new roof. But I think that's been part of it. But you know, every place is a little different. I think having some commitment of the administration that somehow we have to be fiscally responsible. We have to be visionary. We have to look and be ahead of the curve at where things are going. Like all these satellite clinics you heard about. And same thing in orthopedics that Paul is developing. Outreach to the community to make it easy for patients to access care. Urgent care, urgent orthopedic care, urgent medical care. It increases access, decreases costs. It all helps. So, you know, it's multifactorial. It's not a simple answer. But it is true that every place, no margin, no mission. So you got to somehow figure out how to make ends meet. And you know, the loyalty and affection of the alumni for this institution, I don't want to understate how important that has been to this institution being fiscally able to rise to all these challenges. So I appreciate your question, and it is a really good one. And it's going to be an ongoing struggle for everyone, but that's how it is.
Randy, you did a lot of research in lead poisoning in children. Can you say something about it?
Well, we had a program project grant at one point and some other individual grants to study some of the toxicities of lead. And we were interested in lead toxicity in the musculoskeletal system. And really, Dr. Ed Pouzas led all this research. And we looked at lead in bones of animals, or what happened if you gave them lead. And it poisoned the metabolism of the bone and caused weakness of the bone, impaired the ability of fractures to heal. And we were worried that in osteoporosis patients, one of the things we studied was patients who have been exposed to lead all their life with leaded gasoline, and when lead was no big deal, you know. And then we knew that when they became osteoporotic, women in particular, and they lose so much bone resorption when they lose estrogen, that would resorb bone and release a lot of lead. When you get exposed to lead, it gets locked up in your bones. It binds to the calcium there, and it's a repository. When you lose bone for any reason, you get lead going into the bloodstream, and you can get a low level of lead poisoning. So those were the sorts of things we found. And I mean, there's a lot of other work, and a lot of scientists here worked on that. And so lead is not good. We figured that much out. Well, thank you very much for your attention.